So I will give you a brief introduction into endoscopy, just to give those surgeons who are not very aware of where this field is right now, because it has expanded a lot in the last 10 to 15 years. I don't want to take anything from the presentation of Dr. Datar, so I will just briefly show some introduction on endoscopy, and Dr. Datar will give you some details on the transforaminal approach. I will mainly talk about the interlaminar approach after the introduction. So these are my disclosures, and this is where I work. It's a private clinic in sunny Barcelona in Spain. And well, the thing is, what is minimally invasive surgery? Is this minimal invasive surgery, even if some people claim they do minimal invasive surgery, well, this is not minimal invasive surgery. This is the kind of patients that usually comes to my practice, big scars, operated 1, 2, 3, 4 times. And what these patients are looking for when they come into my practice are usually a solution that looks like this. So this is usually what these patients are looking for. And I believe that endoscopy will give you some tools that you may not be having right now in your practice, which could give you an advantage to therapy your patients. So you all know mini open surgery. So compared to open surgery, well, small cut. I've done many decompressions, mini open decompressions myself with the lights and with the microscopes and whatever. After that, the tubular and the microsurgery was introduced. You all know that, especially the neurosurgeons are trained to work with the microscope. And finally, we got to endoscopic surgery. Endoscopic surgery is a bit different of everything else that you have been seeing, because you have all the instruments, well, all the parts that you need to work with, you have them all in one instrument. You have the light, which will illuminate your operating field. You have the optics, which will record and show you on display on the video what you're seeing. You have an irrigation channel, which will allow the water to go into the place and clarify whatever you're seeing. And you have the working channel through which your instruments will go through and through which you will be working. Okay. And well, especially, of course, the Maxmore instruments, I am very happy with them because Jap's father, Tom Hookland, he is the founder of Maxmore, and he was a very renowned endoscopic expert. And he had a lot of experience. So all his instruments are based upon this experience. And you can really feel that when you're working with them, because they have been thought by a surgeon who was very experienced with endoscopic surgery. So in the last years, there has been an evolution in the endoscopic surgery and also the techniques that we've been able to do. So the first generation endoscopes were smaller and longer, and the working angle was about 20 degrees. Then the second generation endoscopes were already a little bit bigger in diameter. The working channel was twice as big. And right now we are the third generation endoscopes, which you will see in the next slides, and which already has quite an important working channel. And it allows us to do many more things that probably were impossible to think about of doing with an endoscope 20 years ago. So there has been a great evolution of the instrumentation and of the techniques that you can do with endoscopic surgery. This is just a very brief overview of the history of endoscopic surgery. I got the slide from Dr. Kim in Korea, but it's a slide I like, well, because he goes way back to Thomas Edison, an inventor of the light bulb, maybe a little bit too far back. But then you have Welch, Storz, and Watanabe, who developed the arthroscopy, which was like the first step into this kind of camera-guided keyhole surgery. And then really what started with endoscopy was with Parvis Kambin and Schreiber, defining the anatomy through which we would be working with in endoscopy. Then you had Hans-Georg Loy and Sang-Ho Lee in Korea, who were big pioneers of endoscopic surgery, who really started to develop the instruments. And then finally we get to Tony Young and Tom Hoogland, Jaap's father, who were, I would say, these were the guys who opened up endoscopy to the broad public. They were able to develop a system and techniques and instruments that made endoscopy accessible to many surgeons. And this is where endoscopy really took off in a way of, you know, popularity. You have, of course, Sebastian Britten in Germany and Dr. Gun Choi, who were expanding the possibilities of endoscopy and the techniques that you can do with them. You have my father, who worked a lot on endoscopic fusion. And well, now we are here doing, well, many different things, which I will show you. What are the advantages of endoscopic surgery? Well, first of all, you do not need to decompress to actually get into the canal. You can get there because the instruments are very small. So as you are not decompressing, you do not need to take out bone and ligaments and all the stabilization structures that are in your way to visualize the nerve roots or the nerves or the dura. You are not destabilizing the segment or the level that you're operating. So you will not need to instrument the segment or the level that you worked on. You are not dissecting tissue. You are actually dilating tissue, okay? So this means by progressive dilation, you're just expanding the tissue. When you take out the dilators or the sleeves, the tissue will close again. So you have much less fibrosis and you're minimizing muscle atrophy. This is just a slide I got from a conference from somewhere else. I could not put in the credits because I do not remember who it was. This is just how muscle atrophy looks like, and you've probably all seen this image. This is white dead muscle tissue after an open discectomy to put in some screws. And this is what happens with the muscle tissue after a wide dissection. And this is something, of course, that you would like to avoid in order for your muscle structures to be still there and stabilize the spine. And the patient has pain with this kind of stuff. And this is how you would like it to look like, you know. So it's this is the healthy muscle tissue, and which is usually how it looks like after an endoscopy. You can really tell no difference between before and after the surgery. One very important thing about endoscopic surgery, which I would like, this is probably the most important message I will try to convey to you today, is how you indicate it. How do you use endoscopic surgery? Okay, because endoscopic surgery allows you to do things that you probably were not able to do with your traditional open surgery techniques. And it's called target-oriented surgery. And I will try to explain this to you with a clinical case. So this was a 74 years old male who came to my practice. He had chronic low back pain, but he had terrible radiated leg pain, which appeared in the last 12 months. And well, he was giving me a VAS of 10 in the back, 10 in the leg, a high ODI score, and he was maxed out on analgesics. He had an oxycodone pain relief plaster, and he was desperate because he was in a lot of pain, but he was also very sick. He was obese, he had renal failure, and when he showed up in my practice, this is the picture I got from him. This is his CT scan. And this guy was desperate because he was in a lot of pain and nobody in my country wanted to operate him. And you ask yourself, okay, why did nobody want to operate on him? I mean, well, if you look at his spine, there seems to be a lot of problems in many levels. You see here the MRI and the CAT scan. You have black discs everywhere. Degenerative spine everywhere, of course, no lordosis. And so the traditional surgeons here were saying, okay, this guy is old, he is sick, and if I have to operate on him, probably, you know, the solution most of those surgeons were thinking of were something like this, you know. And well, I am asking you, the audience, is this the best solution for this kind of patient? Is this always the best solution? And I think this is here where endoscopy comes in and gives you some advantage, you know. What we did with this patient was to think first, we examined him and we saw that he had a very clearly radiating pain on one dermatome. And then we analyzed the images, and we saw, okay, his biggest problem right now is probably the foraminal stenosis he has at L5S1. Because, I mean, the spine we were looking at right now before, he had been having the spine for the last 20 to 30 years, probably. This degenerative spine did not appear in the last 12 months. So something changed in 1 year that suddenly this pain appeared. And this is where we said, okay, let's try to address this thing. And so what we did was we used the Maxmore reamers. You see here how we approach this very collapsed, highly collapsed L5S1. We did the foraminoplasty first with a small reamer. This is the smallest reamer of the Maxmore set with 4 millimeters. We went up to 9 millimeters and did a big foraminoplasty. We could have stopped here because, but as he had such a degenerative spine and he was obese, we thought, okay, maybe a foraminoplasty would be not enough. So we continued, and this is, you see how we did a nucleotomy. This is the end plate scratching. And this is some bone injection, and we ended up putting in an expandable cage. So we put in a cage into L5S1, we expanded it and opened up the foramina with indirect decompression. We did direct decompression of the foramina with the reamers, indirect decompression with the cage expansion. And we did all of this through this small incision. And the result was that the patient postoperatively had a back score of 1, a leg score of 0, and an ODI of 14. So we apparently solved this problem. Don't ask me why the back score went down as well. We thought we would only resolve his leg pain, but as you know, the pain sometimes may confound the patient and they think that their pain comes from the back. Well, it seems to work. So what I'm trying to say here with this example is that do not treat the image. Even if you see a complete degenerative spine on an image, you have to focus on what the patient is telling you. What is his clinic and when did it appear? So ask yourself, what is the pain generator, and address the pain source. What I'm always asking myself is, what may have changed in the last, few months or in the last year for the pain to appear? Because all of your patients probably from a certain age will have a degenerative spine. So, but the pain usually appears suddenly after, and they have pain for the last 3 months or last 6 months. So ask yourself, what changed in that? So you need to do an exhaustive anamnesis. You have to look at your patient. You have to touch him. Do you ask yourself, do I have sufficient imaging? Can I take some conclusions from that? And especially important for endoscopic surgery is whatever you do, you are burning no bridges, okay? So if you do your surgery and it doesn't work, which may happen, okay, especially in the beginning, you still have all the opportunities to do fusion and to do instrumentation. So by doing endoscopy, you're just putting one more step in your therapy scheme or your therapy sequence, okay? So, but if you tell this to the patient, they usually will accept to do as little as possible first and do an incremental surgery approach, okay? What are the limitations of endoscopic surgery from my point of view? Well, first of all, of course, you have a learning curve. This is why most of you probably are watching the seminar, this webinar. So we published with my father many years ago a learning curve about his experience on transforaminal. This is transforaminal endoscopic surgery. As a traditional surgeon, he started learning transforaminal surgery, and we looked at how many patients, number of cases we needed to achieve a 90% of good and excellent results. And we looked at it, and we also looked at the time of surgery, duration of the surgery. And we said, okay, how many cases do I need to get below 1 hour, 60 minutes of surgery? And so when we overlapped both curves, we saw that there was this area between 60 and 80 patients where we saw that the outcome and the surgery duration stabilized. So I'm talking here about transforaminal approach, which Dr. Dettar will detail you. And I believe the transforaminal approach is more difficult anatomically and from the learning curve to learn. So do not be afraid. it may take you 60 cases to learn the transforaminal approach. Personally, I believe that the interlaminar approach is easier to understand, and you'll probably need less cases for the interlaminar approach. Probably around 20 to 30, you'll be already be doing good interlaminar surgery. And of course, a limitation of endoscopic surgery is you need equipment, which is expensive. Yeah, and so you need, this is a typical tower that you need for endoscopy. It's similar to one you would use for arthroscopy. You have a light source, you have the pump that you may or may not use it for the water. You have the cameras, which you will need. You will need an RF probe with your RF frequency generator and the motor. So you have to invest to get there. And what can you do with endoscopy? So there are many different approaches where you can get into the canal and to the disc. These are just some examples of them, okay? And basically, the three most important are these: interlaminar, transforaminal, and the forelateral. I will just very briefly introduce the transforaminal. Dr. Attar will give you more information about that, just to give you an idea what you can do nowadays with endoscopy, okay? So the idea of the transforaminal approach is going through Cambin's triangle, which is depicted here. You have the SAP, superior articulated process, and the exiting nerve root. And if you stay in that triangle, you will probably be safe. You won't be hurting the nerve root. And so one of the approaches that you use is the inside-out approach, where you get into the disc and you try to pull out the tissue. If it's still connected, you try to pull out the tissue from inside, from outside inside, and take it out. This can help for different kind of herniations and even for low back pain. And was the main advocate of this approach was Dr. Tony Young in the US, which probably you will all heard about it, who was one of the big pioneers of endoscopic surgery. Another approach is the outside-in approach, which was developed by Dr. Tom Hoogland. And there you do not get into the disc, but you try to get into the canal. And in order to get to the canal, first you have to do a foraminoplasty, like you can see here. And the foraminoplasty is just reaming the bone with these bone reamers in order to get access to the disc. And well, Dr. Tom Hoogland, Jap's father, was the one who developed this idea. This was a workshop we did in Barcelona with my father many years ago. I'm not in the picture because I was the guy doing the picture. So this picture was done by me, but well, we were very happy to have Tom Hoogland with us there. And I think it was a great workshop. I have heard many traditional surgeons telling me that they are afraid because they have read or they have heard that endoscopic surgery, the biggest problem with endoscopic discectomy is that it has a lot of recurrent herniations. So if you look at the literature, this is a nice paper where they did a review, and you will see that most papers report recurrence between 2% and 10%, okay? So there is, in my opinion, it's also my clinical experience, we have about a 5% recurrence, okay? And so this is a lot of literature, and I do not see, and this paper did not see a difference in recurrence rate to microdiscectomy. Okay, so it states about 2% to 2 to 10%, and the papers that are out there explaining the risk factors for recurrence, it's a protrusion, it's modic changes on the platforms, and instability. So if you know the risk factors and you know how to approach it, usually you will not have a big recurrence. So that should not be a reason not to do endoscopy. This is something we have been working a lot on, also with a transforaminal approach. And what we do is we use the same approach that you would use to do the inside-out approach to get into the disc, and we place a cage in, like you saw in the clinical case before. And we do this exactly with the same techniques, and this is how it looked like. And we've been working a lot on this for the last 15 years. And it is a fantastic way. As you can see in this picture, you have a very small skin incision. You do not have to take out the facet, so it's facet sparring. You don't have to take out bone, no ligaments, no midline incision. And this is like I don't want to say the others are not, but this is like a true TLIF because you're going through the foramen. This is transforaminal, okay? And you have, of course, a very fast patient recovery, no blood loss, minimal risk of infection, and you can do it awake. We're doing this kind of fusions with local anesthesia, and the patients walk home the same day, okay? So this is a typical case of what we do. You can see the expandable cage, and you see the skin incisions with a small incision on the side to put in the cage. Another thing that is an advantage of endoscopic surgery is that you can bypass scar tissue from previous surgeries. You do not have to go through the minefield that was left behind by other surgeons for you, because you're using different approaches. You have different solutions. So again, you have other options to solve your patients. Like this patient who came to us from Argentina, he had been operated there, and for whatever reason, they did a PLIF with him and put the cage only on one side. And when he came to us, the right side was completely collapsed, as you can see here. But the screws were okay; they were not loosened. So instead of taking everything out and redoing the arthrodesis, this guy's problem was just a radiculopathy because of the foraminal stenosis. Again, we went in there and put in a cage, expanded the foramen, did not touch the posterior instrumentation, and we solved his problem. So again, my message to you is endoscopy is not like a golden solution for everything, but it gives you tools to do stuff that you were not able to do before. So maybe thinking out of the box with these new tools will help you to do a lot of different interesting things. Well, and this is just the literature, the studies that we have been publishing with different devices doing endoscopic fusion. We've been publishing a lot about this. So this is just the idea. This was just a very brief introduction. And now I will tell you about the interlaminar approach, which is like the classical approach you know from your training, like from microdiscectomy. And the interlaminar approach, you use a different endoscope than with the transforaminal approach. It's a shorter endoscope. The working channel is bigger, and the diameter of the endoscope is also bigger. And the angle can vary between 10 and 20 degrees. So the indications are for herniations, especially migrated herniations at L5S1 and L4, L5. And you can get very, very nicely the herniations that are under the axilla. Massive herniations are fantastic with this technique. You can also solve unilateral recessive stenosis, and you can solve central canal stenosis. Okay, so these are the main indications that I see for the interlaminar approach, and we will go through each one of them now in this presentation. So first of all, what is useful, especially in the beginning, is to check in an X-ray the size of the interlaminar window of the patient. Okay, especially if you're just doing a discectomy. So you take a standing X-ray and you look at it. Oh, this patient has a big interlaminar window, so we'll have no problem to get in there with my instrumentation. As soon as you have more experience, you will be able to decompress and open up the window. But whenever it's possible not to further, invade and have to do decompression, then even better. So a good planning is always important. The position is just a prone position. If you do a hip flexion, this will help you take out the lordosis, will help you to open up the windows, so the access will be easier. Usually I work with general anesthesia, but you could do it with local anesthesia, doing blocks, interfacial blocks. You will need the fluoroscope, and neuromonitoring, in my experience, is not necessary, okay? Usually for interlaminar approach is not necessary. So these are the instruments that you use for the interlaminar approach. It starts with a dilator and the working sleeve. And when you place your patient, you do your X-ray. You can touch the posterior spinous process. So you don't even need to do the X-ray there. You could do it by palpation, and you just very closely laterally to it, usually ipsilaterally to it, you place your endoscope like this. And when you take a look at the lateral view, you look for the facets. So this is where you want to go. Okay, this is usually where you want to place your instrument. And once you're there, then you have your sleeve is placed and you can put in your endoscope, and then you work with your monitor in front of you. Okay, these are the instruments that you can use with the interlaminar system, the Carrison punches with different diameters, grasping forceps, dissectors, hooks. So everything that you're used to with the usual surgery, but everything is smaller. Okay, this is a small video showing you a big herniation of a young lady that came to my practice. You can see at L5S1 with the Modich changes here and the big herniation that she had on the right side. So we went with this interlaminar approach. You can see how I'm clipping here the ligamentum flavum and opening the window. You have to be careful always because the big herniations are pushing the dura to you. So as soon as you make space, the dura will come to you. As you can see here, the dura is already pushing out to the space that you're creating. Okay, so you can open up the ligamentum flavum and slowly open the space. So now you can turn, as it is a beveled cannula. By turning it, you can move the neural structures to one side and protect them while you're working. And you can see how the herniation just because of the pressure it was generating just really came into the cannula as soon as I was turning it. And you can see how I'm taking out the whole herniation here away. It was a big herniation. So this is a nice, easy case to do, especially if you're starting with endoscopy, because well, it's easy to find the herniation. It's easy to get there. So that would be an interesting case to do. Okay. So this is the cleaning of the whole chunks. Okay. You can use the radiofrequency electrode to coagulate if you have some bleeding, and then you can check the neural structures if everything is okay. And especially you see the dura pulsating, the nerve roots pulsating if they are free. And this was the herniation, very big herniation, about 5 centimeters that we took out. Okay. The last time I did this presentation, I had some colleagues asking, what about the Modich changes? Why didn't you do anything about the disc? And again, as I was telling you before, this patient, I oriented myself not by the images, but mainly by the patient's clinic. She was young. This was her first herniation. So going for fusion here in a patient who had only a radiculopathy, she was not indicating any kind of low back pain. So going here for a fusion, being this the first herniation in a young lady, in my opinion, would have been going too fast. I talked about it with her. I told her probably in the future you might get back problems and then you will need a fusion. But for this first time, I just told her, let's get out the herniation. And she was doing fine. And the pain was gone. She was happy and she went home. And this was a few years ago, still haven't heard of her. So maybe we just bought her some time. Okay. Of course, you can think differently, but this is my approach. I try to be incremental with my invasiveness. This is just a nice patient where we did the same thing, caudally migrated herniation. We did an MRI after the surgery. And this is a nice idea of how you can get out the herniations. So how about decompression? So you have different types of spinal stenosis, as you know. So you have unilateral recessive stenosis, which just has compression on one side. The patients usually have a very clear clinic and have radiating leg pain on one side. And you don't find an herniation, so you should be suspicious of a unilateral recessive stenosis. You can have a central canal stenosis, where you have the whole canal compressed, and you can have foraminal stenosis. And for foraminal stenosis, I do not recommend interlaminar approach, and Dr. Dettar will tell you how you can solve this with the transforaminal approach. Okay, but for the first two ones, unilateral recessive stenosis and the central canal stenosis, the interlaminar approach is, I believe, the best approach for this. And this is just a video I made of the dura. You can see how the dura is invaginated here. So it's kind of folded up in itself, because of the compression from the sides. So this is a sign. I haven't seen it in the literature, but probably it's described somewhere. But this is something I have seen myself many times when you have this stenosis and you see this invaginated dura. So you know that there is a lot of compression on it. Okay. So one way of solving unilateral recess stenosis is doing an ipsilateral midline decompression, which is like this. And I will show you one case video where I did this. So this was this patient had only clinic on one side, L4, L5. So the approach is very similar. You first do soft tissue shrinking, you expose the ligamentum flabum, and what you try to do is you try to stay at the bony side of the ipsilateral side of the interlaminar window. Okay, if there's no interlaminar window, then you have to create it. But so you're staying at the place where the ligamentum flabum, the insertion of the ligamentum flabum at the lateral side of your window, and you just progress, as you can see here, with a high-speed burr and the Carrison punches, leaving the ligamentum flabum first intact. Okay, leave it in place because it's protecting the neural structures. You can see here now I'm seeing. Starting to see the neural structures, but I still keep the ligamentum flabum because especially if you work with a high-speed drill, you want to protect your neural structures of any slippage or whatever may happen. Okay, so just stay to the bony side and you go down. You're undercutting the facets in a certain way because your endoscope has an angled view. So you're not going just straight down. You're going down with a certain angle, and then you can expose and try to find the neural structures. So you can see here how I slowly am progressing and taking out the stenosis on the side. Okay. So, and you can see here, you can see the nerve root at 3 o'clock. Okay. I try to locate the disc to be sure that everything is okay. Yeah, that nothing. There are no disc structures there oppressing. Okay, and try to clean out the whole space. And you can see the nerve root here how it was exposed. So when you see the nerve root, you know that you have decompressed enough. Okay, so when you want to solve central canal stenosis, you need to do first the ipsilateral line, just like we did now, and then you do this over-the-top crossover contralateral decompression, undercutting the facets. You go below the spinous process, and you go to the other side. Okay. This is a very nice slide I got from Dr. Ito in Japan, where he tries to explain how the ligament is inserted into the laminas. You have always these two layers of ligamentum flabum, and you have to be especially careful with the deep layer of the ligamentum flabum, because especially in old patients with central canal stenosis, it can have attachments to the dura. So be careful when you take out the ligamentum flabum, the deep layer, because you may accidentally hurt the dura and do a dural tear when you take it out. Okay, and the idea is, with the central canal stenosis, you start ipsilaterally, and then you can clockwise. You can try to decompress. Okay, so many surgeons have asked me, okay, so now I have an endoscopic approach. I try to solve the central stenosis, but how much decompression is enough? When do I stop decompressing? And if I stop, did I decompress enough? What are my references? Which are my landmarks to know that I have done enough? Okay, so usually the anatomical landmarks to know that everything is fine and that you did enough and you can stop, because if you take out more than 50% of the facets, you will destabilize the segment. So you have to be careful not to overreach, but at the same time, you have to be sure that you have done enough. Okay, so usually your landmarks are the pedicles on the cranial and on the caudal side. Okay. And on the left, on the ipsilateral and the contralateral side, you have the traversing nerve roots. So if you see the nerve roots on the sides, usually you know that you have advanced enough and you should stop in order not to take too much out of the facets. And if you see cancellous bone, then you know that you are the pedicles, okay? You can also use, of course, the fluoroscopy to orient yourself, but these are two tips that usually help to know if you've done enough. This is just a last video of a case this was a 96-year-old patient. We have very old people here in Spain because they eat very well and they take their siestas, okay? And this guy with 96 years old, he had 2 levels of central canal stenosis. And so this is the same idea. With 96 years and with 80 years and probably above 70 years, you will not find an interlaminar window. So you have first to use the fluoroscope to orient yourself, and then you have to slowly progress with the drilling and open up the window yourself, because everything there will be calcified. The ligamentum flabum will be calcified, and everything will be bony structures. So you will not have the references you have with younger patients, okay? So do not try to do central canal decompression as your first case, would be my recommendation, okay? You first have to be acquainted with the instrumentation and with the approaches and the anatomical structures. But the idea is basically the same. As you can see here, I am progressing at the sides of the ligamentum flabum. I'm slowly opening up the attachments of the ligamentum flabum on the one side. When I have the feeling that I have done enough, then I take out a bit of the ligamentum flabum to expose the neural structures. So you can see the dura below. And as I told you, be careful with the deep layer, okay? And you can see here again, this invaginated dura. You can see how it's pulsating now that we have opened it up, but it's still invaginated because of the compression, especially at one side. So I have to keep on decompressing because you can very clearly see, this is the advantage of the endoscope. You can see how the dura here is compressed and it's bulging. This is the nice thing about endoscopy, that you see things that usually you do not see with the microscope or just with some loops. So I just keep decompressing on the ipsilateral side, and here you can see how I expose the exiting nerve root, okay? So I know this side I did enough, okay? And I use the probe to see if there is space, and then I have this whole idea. And then the next level, I don't think we have to watch the next level. You get the idea, okay? So this was the pre-OP myelography of this patient, and you can see how we were able to reduce the stops that you had at the levels that were compressed. Here you have the axial views. So it's very nice. And if you look at the soft tissue structures, you can. It's really hard to tell that you actually did something. You have to be careful with that. You have to explain it to the patients, because unless you do a CT scan, it's difficult to see what you actually did. But of course you did it, okay? And the same thing you can do with cervical spine, okay? You can use the same instruments for the cervical spine. So traditional open cervical spine surgery, usually, if they do an open discectomy, many surgeons, I got this from Dr. Assis, who posted this case in LinkedIn, which is, I just took it because it's the usual thing that many people do. You do a big discectomy, because of the open approach, you take out many stabilization structures, and most surgeons feel better if they put in a cage or something to stabilize to avoid kyphosis. Yeah, so there are many structures in the open approach, many soft tissue structures that you can harm with the esophagus, the recurrent laryngeal nerve, the trachea, the carotid artery. So yes, we are trained to do this, to do this approach. It's classical and everybody's doing it, but the problems, the complications that can arise when you do it, especially if you do multiple levels. Then you can have hematomas, you can have edema. Most people require, or most patients require to stay one night at the ICU just for observation, just in case there is no hematoma and there is no trachea compression. So you don't have this problem when you do an endoscopic approach, because it's very minimally invasive. You can do it even with local anesthesia. Dr. Gon Choi does it with local anesthesia. And you do not destabilize the structures. You keep the annulus most of the annulus you keep intact. You do not touch the ligaments. You have no problems with edema, hematoma, and bleeding. Okay, and so you can do cervical spine surgery with endoscopy in an outpatient, as an outpatient clinic. Okay, and of course you don't need opioid analgesia. So there's two approaches to get there. For broad-based paramedian herniations like this one, okay, so you have a big broad-based herniation there. I recommend the anterior approach. So you go from anterior, and this is how I usually do it. Usually I place a needle there. I do some discography. Then you use the dilators. This is a dilator to get into the disc. Then you place your sleeve, okay, and once you've placed your disc, your sleeve into the disc, you can work through it just like you would do in the lumbar in a lumbar endoscopy. Okay, you can see here how I use the forceps to clean the disc. You can get into the canal, and well, I used to do this with the C-gun, which is also from Max Moore, and I learned this approach with Dr. Gun Choi in Korea. And he was very, very, very generous to let me go there and see how he does it. And last time I had many surgeons telling me, so you're doing a discectomy, and what happens with kyphosis if you take out the nucleus? Won't you be having a problem? And well, my answer to this is just one of many papers that have been published recently. This is a group from Dr. Bartels in Holland, in the Netherlands, and he is a very known expert of the CSRS, the Cervical Surgery Research and Spine Society, and he compared the treatment of cervical herniations with 3 surgical modalities. Okay, so they compared the long-term results, 10-year long-term results of patients who underwent a single-level discectomy, a single-level fusion with a cage, or a single-level replacement with a artificial disc. Okay, and with the disc processes, and they saw that there is no long-term differences for one level in whatever of these 3 modalities. And these guys were not doing endoscopically; they were doing open discectomy. So if you do an open discectomy, you will not have an increased risk of kyphosis or an increased risk of long-term outcome differences compared to doing a fusion. So this is my response to most people who tell me, oh, doing a nucleotomy is bad, you're destabilizing the segment. The studies I read, the people I talk to, they all go in this direction. This is just a very short video of how an anterior approach looks like. So you will see if the video works. Let me try again. Okay, here we go. So this is the discography, the placing of the cannula, and this is what I see with the camera. Okay, and you will see that the nucleus, the degenerated nucleus, has a blue color because of the discography, and then yeah, you can see the platforms of the disc closing in the end, and then you can work yourself all the way through the disc until you get into the canal. And so this would be a regular thing. This is a patient where I did 2 levels, and you can see that the incisions are very, very small. This is how it looks like after the surgery. So we're talking really about most of the time I don't even have to do a stitch to close these wounds. Okay, and this is the nucleus that you can take out. You take them out the pain. And now lately there are several people who are using the same endoscope that we're using for the lumbar approach for this anterior approach in cervical. This is Dr. Lim from Korea, and this is just a small video where he shows that he's doing, you see this big herniation, and he's going from anterior, you see broad-based. Oh, I would like to skip this part, but well, you will see he's using a big endoscope to go from anterior. So the only thing I'm trying to tell you is you're not limited to a small endoscope. You can use a big endoscope too once you're familiar with the approach, and then you can do it. He's even doing a fusion, ACDF. So he's doing endoscopic fusion, placing cages with the endoscope, which is great. So this is just to give you an idea. This is just how fast endoscopic surgery is evolving. Constantly, there are guys all around the world, doing new things that we would have thought this would be not possible. Even myself, I thought you cannot put in a 9mm endoscope anteriorly, and yes, you actually can. Okay, so you can see this video. Well, it's around there in YouTube. You can watch it. I would have loved to. I cannot fast forward it from here, but so just to give you an idea that everything is possible. Okay, and you're not limited to whatever. So you see the endoscope. He's doing this anterior approach here. So great stuff. Absolutely great stuff. Okay, so the posterior approach with endoscopic cervical surgery is, especially, the anatomy. You see, the nerve roots usually have two components. This is a picture I got when I was doing one endoscopy. You see it very clearly here, the two branches of the nerve root. And the posterior approach is usually for herniations that are clearly on one side, and for foraminal stenosis. Okay, so it has not to be paramedian. It has to be clearly on one side, and you can use again the same scope that we were using for the lumbar endoscopy. And of course, as we were talking, paramedian herniations, bilateral foraminal stenosis, instability, you should not do this with these cases. And how you do the posterior cervical? This is how I place the patient. Okay, you try to get the spine as straight as possible in the X-rays, in the fluoroscopy. Then you have to mark your landmarks, facet joints, midlines, and then you place your cannula. And this is a case I did not long ago of a patient. She was very unlucky. You can see it on the right side, the stenosis she had, and she was very unlucky because her pain started just before the lockdown here in Spain, which was in March, and she had a horrible arm pain, and all the hospitals were closed. We could not have surgery. So when she came to me, she was desperate. She had terrible pain in her arm, and so she came for a solution, and this is what we did. So you can see here we are opening up the facets with the burr, and then you can use again your Kerrisons. As I told you before, you have up to 1 millimeter Kerrisons, so you can work in a small space. And then you're exposing the cervical myelin, of course, here with the ligamentum flavum, etc. You have to be very, very careful structures here. And actually, I see an advantage of using a bigger endoscope for the posterior approach, because while you're creating a space, you are pretty safe that your endoscope or your sleeve will not slid into the canal. With a smaller endoscope, you would have danger of your endoscope actually slipping in once you have done your decompression. So this is the nice thing that you do. And so slowly, you can see here how I'm slowly progressing. And here you see the branches of the nerve root, as I was showing you before. So very, very nice. Sometimes you even have two nerve roots at one level. You have anatomical variations. And you can see how I'm trying to mobilize here the neural structures, checking if there's something below it. You have to be careful not to mobilize too much, because your patient might get dysesthesia. Okay, so be careful not mobilizing the nerve roots too much. Checking again that I'm in the disc, that the disc space is free, no herniations coming out. And here I'm exposing the disc fragment that was compressing her nerve root. You can see here. And it was a very small fragment, very small. And here I'm taking it out. Here you go. Okay. And that's it. And so now I'm checking that everything is free. You can clearly see the axilla of the nerve root. Everything is fine. Okay, free space. This was the incision I did on the patient. You see It's 1 centimeter incision. And if we take a look at it, this was the patient. I saw her 1 week later, and this is a 5-cent euro coin. So you see, you're doing a very, very small skin incision to solve this patient's problem. Okay, this image I got from Dr. Van Dalen in Belgium, which is very nice because I didn't do a CAT scan on my patient, but you can see this is about the idea of the hole that you do with the decompression. And again, do not take out more than 50% of the facets, or otherwise you will get instability. So just to summarize and conclude my talk, so this stenosis endoscope of Max Moore, it has allowed me to do many things. In the lumbar spine, we saw the lumbar discectomy for herniations, the unilateral recessus decompression for one side compression, stenosis. I did central canal decompression, even in very old patients. You can do the cervical posterior approach, as we just saw right now, to do a foraminotomy, to do central canal decompression for myelopathies. And you can even do anterior approaches for paramedian herniations and nucleotomies for annular ruptures and even ACDF. So in my opinion, this scope is just like a Swiss knife. It allows you to do almost everything. And what you cannot do with this scope, you do with the other one, which Dr. Datar will tell you how it works. Okay, but I think this is a great tool. And this is just the end or the stage after 30, 40 years of development of endoscopic surgery. And with the development of even better generations of scopes, we have gotten more and more expansion of the indications and solutions that we are able to offer with endoscopic surgery. And this is it. So thank you very much for everyone for listening.